Well, thank you very much for the kind invitation to give my talk on colorectal liver metastasis and liver transplantation. I hope you can all see my screen. Okay. The current paradigm in management of colorectal liver metastasis until now has been what I would call a rather black and white picture. So essentially, you have the resectable disease that is termed as potentially curative, but the vast majority, maybe 80%, are left with only palliative oncological therapy. And the population survival in that group is, despite all efforts to improve oncological care, is about 10% at 5 years. Now, this has a profound effect on how we approach this disease because everything is done in order to make patients resectable, in order to give them hope. But what we can really do with liver transplantation is that resectability is no longer an issue anyway. But if we are going to transplant patients for this disease, we have to make sure that we are dealing with liver-only disease. We have to be able to select patients in a robust way, similar to other indications in transplant oncology. And we have to produce outcomes that are acceptable compared to established indications for liver transplantation. And lastly, the immunosuppression we are going to use should not adversely affect the cancer-related or cancer-specific outcome. Now, liver-only disease, is this a clinical reality in colorectal liver metastases? Well, there are different ways of looking at this. If you look at resection studies on colorectal liver metastases, a pretty large population, it's evident that, first of all, recurrence is a very common phenomenon, but recurrence, about 30 to 40% of the patients recur in the liver. And the majority of these patients, when they re-recur, also recur in the liver. So this is highly suggestive of the fact that liver disease, at least for a prolonged time, is a clinical reality. The other finding supporting this notion is, of course, that you can look at what is the cure rate of liver resection of colorectal liver metastases. And that is dependent on patient selection, obviously, but it lies anywhere from 25 to 30%, meaning that these patients have been disease-free for over 10 years after liver resection. So it seems that a sub-cohort of the patients with colorectal liver metastases have their disease limited to the liver. When we transplant for malignant disease, the principal and the relevant outcome measure is transplant benefit, meaning that the survival gain offered by transplantation, in this case, treatment B, has to be much higher than the best conventional therapy, in this curve signified as A. In addition, we have to gain an absolute survival outcome that is above a given minimal limit. And most transplant professionals would say that this should at least be 50%. Personally, I think it should be slightly higher than that to justify the allocation of liver grafts. But this figure will, of course, be quite dependent on which kind of system you work in, the waiting list times, and waitlist mortality. This whole concept started in 2006 with a proof of concept trial. it's very important when you look at this trial to be aware of the fact that these were not highly selected patients. They were, to be frank, quite difficult to recruit because this was such a paradigm shift, and there was a lot of resistance. So many of these patients had very progressive disease. In fact, about 60% of them had progression at the time of inclusion. Nevertheless, we were able to show that you could obtain 60% 5-year survival at 5 years, which is, of course, much better than the expected 10% survival. But given that this cohort was not optimally selected, it allowed us to identify predictive factors that are related to survival outcome and gave rise to the so-called Oslo score. And there are this consists of these 4 parameters: maximal tumor diameter or above 5.5, pre-transplant CEA above 80, progression on chemotherapy, and time interval from diagnosis to transplant less than 2 years. And perfect selection would be an Oslo score of 0, and the worst predictive outcome would be expected in an Oslo score of 4, and this can be seen in this curve. So essentially, everyone that had an Oslo score of 0 to 1 survived, were alive at 5 years, whereas no one with Oslo score 4 lived beyond about 3.5 years, clearly suggesting or indicating the importance of patient selection. So the 10-year data of this study was published in 22, and you can see that the group of Oslo scores 0 to 1 have and these are not estimated survival data, these are actually observed survival data for all patients. So the 5-year survival of Oslo score 0 to 1 was 75%, and the 10-year survival of the same cohort was 50%. And this is in line with many of the conventional indications for liver transplantation. The sequel study, SICA-2, was a study where the effect of more stringent patient selection was tested. In essence, in the first study, there was no requirement for an objective chemotherapy response. There was no limit on tumor load in the liver and so forth, and there was no standardized minimal observation time. So in the SICA-2, all patients were observed for at least 1 year. They had at least 10% response RECIST, and we tried to avoid very large tumors, and they have all completed first-line treatment. And in this study, we ended up including only patients with Oslo score 0 to 1, and the survival at 5 years was 83%. Clearly indicating the importance of patient selection. Now, these are only 2 of the trials that are important to know, but during these 10 years that it took, there was a lot of international interest, and international hepatobiliary association published guidelines based on the evidence so far, and these are quite useful in illustrating how you can approach the selection process towards transplantation. So basically, the way to do it is to try to pull out the patient that has obvious negative predictive factors during the workup. So extrahepatic disease is an obvious exclusion criterion. And the patients should also fulfill certain molecular criteria. And so patients with the BRAF V600 mutation, we know that these patients do far worse nearly with any oncological therapy apart from the new drugs against the mutation that has been released quite recently. And MSI patients have the alternative of immunotherapy. And immunotherapy, as you know, would not mix very well with transplant, so these are excluded from transplant consideration. There are also certain factors linked to the primary tumor pathology that needs attention. We need to ensure that, we need to ensure that the primary has been radically resected according to state of the art. Node N2 involvement is a negative predictive factor, and it's not an absolute exclusion criterion, but if you have an N2 patient, you need to observe them for a longer time. And undifferentiated tumors or signet ring cell differentiation they are usually much more aggressive and should be avoided. And also right-sided primary tumors do universally much worse. And this is in fact also irrespective of whether you transplant or you resect or you give chemo, right-sided primaries have a worse prognosis. Then response to chemotherapy is probably the single most important clinical factor. Tumors that doesn't really respond well to chemotherapy are never going to be transplant candidates. So we require at least 10% response. And why 10%? Well, this is the way the RECIST criteria are designed. Stable disease is defined as plus minus 10% response. So you have to make sure that you have a degree of response that does not include progression. And this response should be durable and stable over time. And the CEA should be below 80. Now, an important thing that is not included in these guidelines that we try to get the other authors to accept is the use of PET to assess tumor biology. This is, to my opinion, a highly underutilized way to assess colorectal cancer. Normally, we use the PET scans primarily to exclude extrahepatic disease. But these images contain much more information that can be used to stratify patients prognostically. So basically, the way this is done is that you measure what we call the metabolic tumor volume. And the metabolic tumor volume, MTV, is the lesional uptake that is at least 40% of maximal standardized uptake volume. This can be calculated for each lesion and then summarized as one value per patient. So in the upper panel ABC, you see a patient, he actually has multiple small nodules in his liver, but only one of them has an increased uptake. Whereas in the lower panel, DEF, you see a similar patient with a big tumor incorporating most of segment 2 and 3 and 4, and a very intense uptake. So obviously the MTV in these patients are highly different, and the outcome is highly different, as I will allude to. So the use of MTV in colorectal metastases is not exclusive to transplant, but it hasn't really been adopted well in the surgical oncology community or oncological community. But it has been shown very clearly that if you measure MTV before you start chemotherapy, Patients with a very low MTV do much better than patients with high MTV values. So the cutoff value is about 4.5 cc in chemotherapy. Similarly, we have shown that if you look at the liver resection patients that have a MTV below 6 cc, they all survive after liver resection, 100% survival. Whereas if you have higher values, you're looking at a 5-year survival of about 40%. Interestingly, the cutoff value we have identified in liver transplantation is 70 cc, about 12 times higher than that's seen in liver resection. And how this works is that using the MTV allows us to evaluate biological tumor load rather than just morphological or radiological tumor load. So you can see in the upper panel that here we have a patient that has 40 liver lesions. He has a tumor burden score of 40.2, which is extremely high, but his MTV is 0. This patient was transplanted and is still alive without recurrence. Here, a patient with 25 lesions in his liver, a low MTV of 25.2, 46.3, very high tumor burden score, alive and well beyond 5 years, whereas this patient has a very high MTV, just 7 lesions in his liver, and the survival was only 2 years after transplant. So the MTV, if you look at the effect of number of lesions on survival after transplantation, you see that the MTV clearly modifies the impact of tumor load. Either if you look at this as number of lesions or tumor burden score. So the green curve here are patients with low MTV, excuse me, and the red curve are patients with high MTV. This effect is lost if you have large tumor diameter. So large tumor diameter by itself is a bad prognostic sign in transplant. In other words, if you give maximal oncological therapy to your patients and that you can't downstage them below 5.5, that's not a very good sign. They will probably benefit from transplant as compared to chemo, but you're not very likely to produce an outcome that would be outstanding in terms of allocating deceased donor livers. So to put a long story very short, if you're going to transplant for colorectal liver metastases, it's a matter of selection. This is not a one-size-fits-all therapy. You avoid negative predictive factors, as alluded to previously in the talk. You require a sustained and robust response to chemotherapy. You make a predictive scoring and make sure that the patient has an Oslo score below 2 and as low as possible. And you should absolutely do PET scores before listing and ensure that the metabolic tumor volume is below 70 cc's. Now, it's important that when the PET score is done, the patient should be off chemo for at least 4 weeks, so we are measuring an unsuppressed PET. Otherwise, you might get a false low reading. And the results of our more collective experience in a high number of patients was published in JAMA Surgery in 2023. And as you can see, these factors, an Oslo score of 0 to 2 is a very robust way of selecting patients, and the single components, tumor diameter and response to chemo, and CEA level are highly reproducible and robust way to select patients. Now, what about recurrence? Anyone that has dealt with colorectal limb metastasis know that this is a challenging disease, and the incidence of recurrence is high. Even in liver resection of a few lesions, you have high likelihood of recurrence. The interesting thing is that if you compare liver transplantation to liver resection, the pattern is very different. So the majority of patients that have recurrence after liver transplantation actually have lung recurrence. Whereas after liver resection, you have about a third of the recurrences are at multiple sites, about a third in the lungs, and about a third in the liver. And this translates to a different impact in survival outcome. This is illustrated by the left panel here. This is a patient I transplanted in 2007. She came back with a little lesion in her lung, was otherwise well, her liver was fine. And what we do when we see lung lesions is we do absolutely nothing. We don't give chemo, we just observe them. And these lung lesions typically grow very, very slowly. So basically, our approach is that we resect them when they become larger than 10 to 15 millimeters. And the reason for that is that if you go in too early, the thoracic surgeons might miss the lesion and you have done everything in vain. And usually you can observe them for quite a prolonged time before you resect them. We looked at the growth rate of lung lesions in the transplanted population and compared them with rectal cancer patients that had been resected for lung metastases. And interestingly, in comparing the growth rates of lung metastases in these two populations, there is absolutely no difference whatsoever. And this is important because this group, the Zika population, are immunosuppressed, whereas these rectal cancer patients with the control group have no immunosuppression. And that indicates one of the great fears when we started the program was that everyone postulated that the immunosuppression would make the disease explode. This is simply not true. We have never seen it in our whole practice. So the take-home message with regards to recurrence in well-selected patients is that, of course, if you have multi-site or unresectable recurrence, this will be linked to inferior survival, but about 60% of the relapses are pulmonary mets. The majority of these can be resected. They're usually slow growing and doesn't really impact the patients very much. And we currently believe that a lot of these are actually staging errors, meaning that we have probably in quite a substantial portion of patients, transplanted patients with minimal lung disease that was not reliably detectable at the time of transplant. So the reality is that what we have all learned in cancer trial is that we use disease-free survival as a surrogate endpoint of treatment efficacy. This is meaningless in transplant for colorectal metastases because if you plot disease-free survival in the left-hand curve against overall survival, you see that there is no correlation whatsoever between disease-free survival and overall survival, simply because a lot of the recurrences are treated with curative intent. And the same is to a large extent true also in disease patients. So the reliable outcome measure in liver transplant for colorectal metastases is overall survival and not disease-free survival. Now, yesterday was a big day for everyone interested in the topic because the Transplant trial was published online in the Lancet. Sorry? I will just go on. So the Transplant paper was published yesterday in the Lancet, and this is the first randomized trial looking at patients that are clearly unresectable and comparing liver transplant plus chemotherapy versus chemotherapy alone. In the intention to treat setup, the survival at 5 years was 57 against 13. And in the per protocol comparison, the outcome was 73% 5-year survival in transplant versus 9% 5-year survival in chemo. So clearly supporting all the research our group has done for almost 15 years, indicating that liver transplant can really provide a substantial treatment benefit in colorectal liver metastases. Now, going back to the black and white picture, this is the state-of-the-art treatment algorithm of colorectal liver metastases, and the transplant study and our own trials clearly will have an impact on how we see unresectable disease in the future. As you can see, the black and white way of looking at the disease makes surgical oncology very focused on resectability, meaning that you do anything you can to try to make patients resectable. And evaluation for transplant is placed in the lower right-hand corner in those that, well, you can't resect and the tumors are controlled by chemotherapy. I think this is an oversimplification, and I will try to allude to why. The reason for saying this is that technical resectability is really not a biological criterion. It has also been shown that even among expert surgeons, it's more like a throw of the dice, because technical resectability is mostly reliant on anatomical factors, size of the future liver remnant, quality of the future liver remnant, and tumor load. And you don't have to know very much about technical resectability to understand that in the toolbox of the surgical oncologist, transplant essentially solves all these problems. So we might have to look at resectability as an exclusion criterion in a new way. You could speculate whether in some few patients, maybe 100% liver resection could provide a clinical relevant survival benefit compared to partial liver resection in some patients with, for example, bilobal colorectal metastases. And the reason for saying this is that the outcome of liver resection is not standardized. It's highly variable. So it will range from about 20% survival to 100% survival, depend on multiple factors. And there are a lot of predictive factors for outcome in liver resection, and if you look at them, they are very similar to the outcome criteria we use in liver transplant for colorectal metastases. And one of the most consistent features that every score looks at is the tumor load in the liver. So tumor load in the liver is a highly predictive factor for outcome after liver resection, and it's also predictive to a lesser extent for the outcome after liver transplant. If we look at high volume disease, it's a minority of the patients with colorectal liver metastases. In the LiverMet survey, which is a live registry, it's about 7% of the patients that have high tumor load, defined as more than 7 lesions. But what we know is that in the upper panel, you see a large cohort study published in 2017, just looking at the effect of number of lesions in the liver and outcome. And as you can see, best outcome is when you have very few lesions, just like 1 to 3. But as soon as you exceed more than 4 to 9 or over 10, the outcome will be much worse, and you are approaching about 20% survival if you have more than 10 lesions. So claiming resectability is, well, it can exclude you from transplant in the current setting, but it doesn't necessarily provide you with a good outcome, to be blunt. The same is true for tumor burden score. So you might, as a hepatologist, you might wonder what tumor burden score, and I can shortly explain it. So tumor burden score seen in the lower graph, the gray one here, you plot each patient in this Cartesian plane by recording the maximal tumor diameter and the number of tumors. So each dot in this graph is a patient. So the tumor burden score is by definition the distance of the dot from the origo. And this can easily be calculated by the Pythagoras theorem as the square of the tumor diameter and square of the number of lesions, and you take the root of that, and then you have your tumor burden score. So in other words, if you have 9 tumors of 1 centimeter, you have a tumor burden score of 9. So a tumor burden score of 9 is what is in zone 3 of this panel, and in zone 3 of this graph. If you have a tumor burden score of 9, your 5-year survival will be approaching 20 to 25%, with a confidence interval ranging from about 15 to the high 20s. So it's not a very good survival, as you can see. The other thing to pay attention to is that if you have high tumor load and you're a resect patient, it's very interesting that in the lower tumor burden score, there's a clear benefit of having what we call an R0 resection, meaning that you have a clear margin. Whereas patients with not clear margin have a far worse survival, as can be expected. However, if the tumor burden score is high, this benefit is lost. And this is probably indicating that in high tumor load, we systematically misstage patients, meaning that what you see on the images is not really what you get. And so the probability of understaging patient is a function of the tumor load. So the probability of overlooking lesions is much higher when the tumor load is high. And then, so a lot of the resections that are done in very high volume disease are probably more appropriately termed as palliative rather than potentially curative. Another study clearly indicating this is this study from Rochester, New York. They have a living donor program in liver transplant for colorectal liver metastases, and they have looked systematically at all the explants, and they have shown that there are undiagnosed lesions on explant pathology in 65%. And importantly, lesions with preoperative complete radiographic response harbored viable carcinoma in 57% of the patients. So this just highlights that a lot of the patients with high volume disease are notoriously very difficult to stage correctly and are probably underserved by current resection policies. Now, this all leads to early recurrence, and early recurrence really impacts survival. In the upper panel, you can see a cohort of patients stratified. The blue one is those patients that did not have early recurrence. The green ones had very early recurrence, and the red ones are unresected patients. So there is no significant difference between very early recurrence and unresected patients. And in the lower panel, you can see the same cohort of patients stratified by the time of recurrence. So the earlier you recur after liver resection, the worse the outcome. And it's really also quite interesting to compare the blue curve to the green curve. So the ones that have no recurrence within 24 months, they obviously do very well. But this is obviously a very small cohort of the patients because the green curve is very similar to the blue curve in the upper panel. So the majority of patients recur. And what is the most important predictor of recurrence? Well, it's in this large cohort of patients, it is tumor load. So we really have to start having a more biological approach to colorectal liver metastasis instead of the current black and white picture where we just stratify patients by technical resectability. I think it's a false way of looking at it. And this is more in line with what we currently do with HCC, where we try to predict tumor biology in a better way and just not limit our view to radiographic morphology. Are there any prospective data looking at comparing resection and transplant? Not really, but in a way there is. There is one interesting trial where the data on transplant is not very revolutionary, but I think it really illustrates a phenomenon that will be puzzling us in the years to come. Namely, this paper is from Toronto, where they looked at the management of initially unresectable liver metastases. And they looked at all the patients that were referred to them, and obviously they experienced what every program will experience if you start a program for colorectal liver metastasis and transplant. You will have to look at about 100 patients before you achieve 10 patients that you can transplant. But what they also did was that Toronto is a referral center in Canada. Obviously, they have the highest expertise in liver resection. So they made sure to do a thorough re-evaluation of resectability, and they ended up claiming that 22 of the patients that were referred to transplant, they deemed resectable. So they went on to get liver resection instead of transplant. Now, this cohort of patients, the resectable, are on the left panel, and they are essentially identical to the ones that got transplant. The only difference is that they were deemed technically resectable. If we look at outcome, because this is akin to almost a Transplant trial, although it's not randomized. If we look at the survival outcome, the survival at 3 years is 100% compared to 43% in resection. More importantly, you see that within a year, 19 of the 22 liver resected patients had recurred, and only 10 of them had intrahepatic recurrences only. And again, only 4 out of the 19 could be offered curative intent therapy. So we know how these two populations will go in the future. Clearly, these patients that were not transplanted just because of technical resectability will do far worse than the transplanted with our current knowledge. So I think it's summing up all our own studies, the Transplant trial, and a lot of the other trials on liver resection. I think it is fair to say that with our current knowledge, liver transplantation can provide a substantial survival benefit in selected patients with colorectal liver metastases. On the right-hand side, you see some of the criteria that are associated with very good survival outcome that I alluded to initially, the Oslo score, obviously. Also, the Frank clinical risk score is a very robust way to select patients, and the PET-MTB. Parameters reflecting tumor biology are crucial to optimize patient selection. And technical resectability in high tumor load is not by itself really a very valid exclusion criteria for transplant, according to my personal meaning. We need multidisciplinary management, including transplant oncology, to improve outcome in selected patients with technical resectable disease, as well as in selected patients with unresectable disease. And I think in the future, the question is not to resect or transplant, but to choose between partial or total resection in a few patients with resectable disease, and clearly also to offer transplant to a few patients with unresectable disease. So will the current treatment algorithm stay constant? I think not. I think we will see more patients transplanted for unresectable disease, but I also think more patients will possibly be transplanted with recurrence after conventional liver resection, and maybe in the future we might even, with development of even better criteria, choose transplant as the primary treatment in technically resectable disease, but this remains to be seen, and we need future trials to go into this field. So with that, I thank you very much for your attention, and I'm very happy to answer any question you might have.